So welcome everyone to our ECHO mentoring session. We are a group of palliative care clinicians in Nairobi, Kenya, and other parts of East Africa that are supporting those working in humanitarian settings. And today we're going to be focusing on advocacy in palliative care, especially in humanitarian settings, which often are quite difficult settings to advocate, especially for things such as palliative care. So I'm hoping today you will learn some new skills, you'll learn a bit more about what advocacy looks like, and then we will transition to some examples that have been done in Bangladesh, where Dr. Megan will share what they've done there, which is a similar situation that we find ourselves here in East Africa. So I will introduce, my name is Erin. I'm one of the facilitators and leaders of this program, this ECHO program, and we're so happy that you're with us. We're in the mentoring sessions phase of this program. We're hoping next year to offer the certificate for introduction to palliative care again, so please look out for that. I know we have some people on our call that have been through the certificate program and are continuing with our mentoring sessions. So it's great to see you. If you want to take a minute to put in the chat your name and where you're working, we'd love to get in touch with you. And we do have a WhatsApp group where we regularly communicate. So I will put that link in the chat as well, so you can join us. I'd like to introduce now our speaker for today. His name is David, who works with Kenya Hospices and Palliative Care Association. And he's going to be talking to us about advocacy and how we can advocate for our patients and families in palliative care. So welcome, David.
Many thanks, Erin, and good afternoon, everyone. And probably for those whose time zone is not like us, how are you, everyone? It's great to be here. I hope I'm audible. Great. And I hope you can see the screen well, right? Great. So it's a privilege for me to be given this opportunity to make a presentation on advocacy in palliative care in humanitarian settings. And I'll start with a disclaimer that I may not have a lot of experience in terms of humanitarian grounds or settings, but from palliative care perspective, I know or have a bit of experience in terms of advocacy, because it's what KEHPCA has been doing not for less than 15 years, and I've been really involved in advocacy. And for that reason, I will share a bit of my experience in terms of results of advocacy and some of the things that we've done, and probably put it into perspective based on some of the resources or the readings that are available. And hopefully during the interaction, we could see whether what I'll share agrees with some of the humanitarian grounds and aspects in our settings or in our context. And if you have any questions, I'll encourage you to either write it on the chat box or write it someplace, and then during the interaction, we will be able to share more and answer where we can. Thank you, Erin, for organizing this, and also my co-presenter. I'm looking forward to great learning and great interaction. I work for KEHPCA. KEHPCA is the umbrella body for palliative care and for all hospices. We've been coordinating palliative care as an association since 2007, and we've seen the growth of palliative care service providers from 14 in 2007, 14 sites providing palliative care, to the current 95 sites. And that's an exponential growth, which definitely translates to many people patients and families accessing palliative care services. And it's our interest that even in the hard to reach areas, especially in the Kenyan context, we'll be able to have also palliative care as part and parcel of the services that are provided, even in humanitarian grounds. I've had a bit of an experience with Dadaab refugee camp, and some of the experiences that I got or we got to hear in terms of suffering and people in need of palliative care sometimes can be very overwhelming. And so we acknowledge that there may be many gaps in our context. And that is why we're doing this kind of a talk, so that we all can bring together our efforts and see how we can be able to address some of the gaps that exist. So in my presentation, this is the outline. I'll do some definitions, talk about palliative care context from a humanitarian perspective, unpack advocacy a little bit, results of advocacy, and then we'll go into interaction through question and answer. Based on the topic, what is humanitarianism? I don't want to sound very academic, but it's the benevolent response to the suffering and the needs of others. So responding to suffering or responding to the needs of people. In other words, it's an action to prevent and alleviate suffering, human suffering, whenever it may be found. And the essence is to protect life and health, so that eventually we are able to protect and respect humanity, or what we call influence, having people experience the best quality of life as they live. And so tying it to what we're talking about, advocacy in humanitarian settings. And then again, I ask myself, what is advocacy? It's an act of pleading or arguing in favor of something, such as a cause or an idea or a policy. So basically, it's about influencing people, policies, practices, structures, and systems in order to bring out some change. And I highlighted change because I believe we have a stake or a role to play, people from different perspectives in terms of influencing some kind of change, and more specifically in our setups and in our humanitarian settings. Specifically around policy advocacy, the WHO gives this definition that policy advocacy is defined as the deliberate process of informing and influencing decision makers in support of evidence-based policy change. Remember, I talked about any activity that is done to bring out change. So the policy should be geared to bring in some change, and then policy implementation. And we know where policy implementation is key. Definitely resources are part of that change. And so we have this document, which is like our palliative care constitution, launched in 2021 by the then Her Excellency First Lady, the Kenyan Palliative Care Policy 2021-2030, as looking at it and the pillars that outline or are outlined in the policy. And it befits that even in our humanitarian settings, there are aspects of this policy that should or are implementable even in our settings. And so the reason as to why we advocate for its implementation in all aspects, be it in high resource centers, be it in low resource centers, so that any person that is living with palliative care needs should be able to access the services, irrespective of whether they are in Mandera, Turkana, or in Nairobi, or Nyarukunga. So wherever somebody is, provided they are Kenyan and they are human being, even those in Somalia, they should be able to access that care and support. And hence, the reason as to why we need to advocate for its implementation. Now, in our situation, we realize that the approaches that ease suffering and promote dignity are needed everywhere. Yet, in majority of the humanitarian settings, especially in Kenya, there is minimal integration of health projects. There is, yes, but there could be minimal aspects. And so I pause to get us thinking some of the crises that have happened, especially when there is war. And my first picture is just a demonstration of when there is war around us. And I want us to just put this into perspective. If there was someone in this hut having a life-threatening illness, and this was the situation around them, what would we talk about care and access to care? Looking at these Kenyans, if there was somebody in this hut and they required, say, like stabilization of their kidneys, if they had a kidney disease, or if they have dementia because of being, old or for some reason, what do we talk about access to care? So in times of war and in times of disaster, and sometimes epidemics, like we just had COVID recently, are we able to assure access to this kind of care to ease suffering and to promote dignity to all the people in a uniform way? That's why we're talking about advocacy, so that we put it into perspective. Now, the goals of humanitarian action are threefold. So one is to save lives. Number two is to alleviate suffering. And number three is to maintain human dignity. Like I talked about the three aspects or the crisis, when we watch TV, especially in the recent past, for those who watch news or those who follow news online or any other way, when we see these kind of pictures, I don't know whether we just, block our minds not to see further, or do we ask ourselves certain questions? This young boy here is a Kenyan, and because of malnutrition and suffering, lack of food, look at the kind of suffering he is in. These are people looking for water, and water becomes a scarce thing. By the virtue of being in a humanitarian setting, it predisposes people to a lot of suffering. And again, we have a big discussion around human dignity. How do we help them? And especially more specifically to those who are sick, and not just having sickness that can be quickly fixed by taking pills, over-the-counter pills, like malaria, and I'm not underestimating sickness, but I just want to show the grave aspect of having a life-threatening illness, a condition that will not be fixed immediately, but somebody will live with it as long as they live. So how do we address their suffering? It's our goal as advocates to address their needs. So what does advocacy involve? 4 points. One, it involves influencing the powerful. So how do we influence the powerful? By educating decision makers about their responsibilities, so as they are able to uphold the rights of the poor, the vulnerable, and the oppressed persons. It encourages accountability and empowerment of relationships. Secondly, it involves speaking out and communicating. I was in a forum and the speaker said advocacy is making noise, and not just noise, but targeted noise. So as palliative care movers and people in positions that can influence some change, are we able to make that noise or to speak out and present a clear message based on good evidence and directed to those who can bring that change? The other factor is it is empowering those without power to become their own agents of change. And I remember the statement, nothing for us without us. So them that require this change, when they become key advocates, then they are able to advocate for their own support. That is usually one of the best aspects or the best advocacy ways of ensuring that change happens. It helps those who feel powerless to see what power they really have. And then fourthly, seeking justice. And this is for those who are poor, vulnerable, and oppressed or treated unfairly. So what does advocacy involve? Advocacy involves an organized process that is planned and strategic rather than based on one-off kind of events. So you'll not say you're an advocate by just doing one event, by just walking to the governor's office once. That doesn't make you an advocate. But you need to be really well organized to face maybe the CEO of the big organization in Dadaab, say Camp, Agadera, or wherever, and present some strategic thoughts and some strategic process of trying or coming up with some change. What am I talking about? When we're providing care and support or healthcare and support to patients in different settings, it's the role of the provider of that care to look at that provision of care in a very holistic way. So that if a person... let's mute our mics so that we don't interrupt the session. Sorry for that. So it's an organized process, and it aims towards a desired outcome, and it is also flexible and sometimes unpredictable. So advocacy is an organized process. That is point number one. Number two, it involves asking whys and why again, and asking why until you find the underlying cause of the problem at hand. Sorry, this is number 2, 3, and 4. So we ask ourselves, why is it that in point X, we do not have this care? Why is it that this care is not provided? Why is it that this care, asking many whys until we find a solution to that issue? And then it's about being intentional. So identifying the changes we want to see and the people who can deliver them. And that's about working with change agents to deliver the change that we needed. And again, it involves having a clear purpose. The purpose for palliative care is to alleviate suffering and challenge the injustices that exist, especially in certain systems or in certain structures, in policies and decision-making, as well as practices and attitudes, because sometimes it's because of the practices or attitudes of people that certain injustices happen. I'm sure my co-presenter will be making a presentation on pediatrics, and there are many vulnerable groups who require some kind of change or some advocates to advocate for their needs. So what are the main, sorry, I go through, some people are coming in and blocking the screen. So what are the main approaches of advocacy? There are 3 key approaches to advocacy. One is advocacy for people. So I take myself as an advocate and I do it on behalf of the people. That's one approach. It depends. As an advocate, you can use whichever mode or whichever approach, depending on different situations. So this is advocacy for people on behalf of communities affected by a situation or by people and organizations not directly affected. works in consultation and engagement with the affected communities, and it works in situations where affected communities are unable to speak out. Second approach is advocacy with the people, done in collaboration in a collaborative way between communities affected by a situation and those who are not directly affected. This option works when they are both advocating on the same or a similar issue, and when there is effective engagement with the affected communities. So we could have a team, coming from Nairobi, going to maybe a camp and advocating for such as an issue, or people coming from a certain humanitarian camp, and they come and join us in Nairobi here. We go to Parliament and seek some audience with the Council of Governors, for example, to influence some kind of policy change. Then advocacy by the people, and I like this one, as having worked in palliative care for some time. My experience is when the people advocate for themselves, the people that are directly affected, when they become the advocates themselves, most of the times this bears the best and the quickest response. This is advocacy that is done by communities that are directly affected by a certain situation. It reminds me of a case scenario in one of our counties where the patients who are under palliative care in one of the hospices decided to sit together and come up with an advocacy agenda. They went to the county assembly, presented their paper to the speaker, and they were given some 5 minutes to make a presentation to the MCS during one of the sessions. And within a short while, there was a law, or the county was able to make certain provision so that, those patients who require palliative care in that county are able to be supported with NHIF support. And in many ways, most of the main facilities, the hospital facilities in that county, have integrated palliative care. So at the end of the day, you find majority of the people who require palliative care in that county receive it. It's more affordable, and the people are more responsive to the needs of that population. So that's just to give an example of the different approaches to advocacy. So what is the role of an advocate? This is simple, and it's just to remind us that we speak on behalf, we represent. The role of an advocate is to represent, speak on behalf of the people, to accompany, speak with the people, to empower, enable people to speak on behalf of themselves. When an individual is empowered, you can't do nothing about them. They will push for their agenda, whichever way. Times an advocate models, so to demonstrate a policy or a practice to the people or to decision makers, negotiate. And again, there are modes of negotiations where you're able to confer or certain, to push in your agenda through, the discussions of other people. It's also the role of mobilizing, encouraging people to take action, to influence a decision. And lastly, to bargain, that is to negotiate the settlement of something. So from palliative care perspective and in humanitarian settings, what should we advocate for? So one is developed or expanded palliative care programs or guidelines. Without guidelines, those who provide health care, and I'm glad to hear there are people from Agadera in Dadaab, there is somebody from Garissa, I saw other people from, the far regions of the northern Kenya, that without guidelines, it's difficult to provide, the kind of constructive care. Number two is to advocate for palliative care training. KEHPCA has been undertaking a lot of training in palliative care. I know we've had even contacts coming all the way from the northern side of Kenya. And sometimes when we follow up after the training, in terms of whether there is some bit of practice and having palliative care services running, the response is usually very, maybe do I say devastating, that after training, nothing much really happens. And I could be wrong. Like I said, we haven't quite visited so much in the recent past, especially the humanitarian settings in our country. But we would love to have, and that is why we're doing these kind of sessions, to have more emphasis and having champions whom we can work with to ensure that this training helps, and especially having programs that could address the needs of the people in those humanitarian grounds. Again, we advocate for resources, and when we talk about resources from palliative care perspective, we're talking about personnel or human resources. We're talking about essential palliative care medicines and equipment. We're talking about money, infrastructure also, and at the same time, capacity. And then number 4 is provision of culturally appropriate and sensitive care, so that we uphold dignity and we're able to treat people as human beings and not treating people as slaves yet in the 21st century. The fact that somebody could have a gun wound doesn't require them to continue suffering, even when sometimes, and I know that sometimes these are sensitive topics. I remember recently, one of our policymakers during the vetting sessions in Parliament, or one of the sessions that happened recently, one of the parliamentarians really shedding their tears because of the situation of the county they represent. I mean, it's sometimes really not a very good thing to see suffering and we just go quiet. And so I present the orchestra concept so that we are all encouraged to be part of the change that we so desire. Remember, in an orchestra, based on this pictorial, that there are so many people, and like you can see, they have some equipment that looks similar, and the other equipment which look very different. But if you're a spectator or you're listening from a distance, you'll not be able to tell that it was this instrument or it was this string instrument which made a certain tone. But you will hear in unison one sweet, nice tone, which will draw you to listen and to draw closer and listen more. If we all worked together and talked the same language and played our tunes, each as we're supposed to, eventually we will have a response or a change that everybody would want to come and see, everybody would want to come and identify with. And at the end of the day, we'll have provided that care and support to our clients that they so required and that so fits them. So, ladies and gentlemen, as I come close to conclusion, I have some few questions that I may not have answers to, but just to help us think out of the box, if we are in a box. So the quick questions are, who are the partners we need? Who are our advocacy targets in our Kenyan or in our different situations, humanitarian settings? Do we want to target the government? Do we want to target the non-government organizations or bilateral agencies? These are just few examples, but we need to ask ourselves, what is our target for our advocacy? Number 2, who are our beneficiaries and how do we engage them in our advocacy? Remember the 3 approaches of doing advocacy. Do we want to do advocacy for or with, or the advocates will do it by themselves? So are our beneficiaries the bereaved? Are our beneficiaries the guardians? Are they the employers or children? Are they the key populations? Are they the caregivers? And the list could be longer than this. The other question is, what is the big agenda and how do we connect with it? What is everybody talking about today? Are people talking about the SDGs, the strategic development goals? Are they talking about universal health coverage? Is everybody talking about non-communicable diseases or orphans and vulnerable children? Are people talking about security in our humanitarian grounds? Are people talking about agriculture? What is the discussion about? And how do we pagine, or how do we connect palliative care with all these kind of discussions? Recently, we were doing some program in Eldoret, and I must salute one of the groups that is really vibrant and coming up really well. They were able, patients and caregiver support group, they were able to knock offices, in the county and bring together, policy makers or duty bearers within the county. Somebody came from agriculture, somebody came from education, and there were certain commitments that they made. Eventually, the success of that advocacy will benefit many people in that county, probably in a lesser way to the support group. But eventually, I'm sure the support group will be very happy to see the results of their advocacy. So it should be a goal of everyone to push where we can. And then eventually we need to visualize the change that we want to see. And so it's a reflection to ask ourselves, where are we coming from? What is our past like? How is our now? And where are we going? What is the future supposed to look like? So ladies and gentlemen, those are my quick thoughts on this and a bit of references. I'll be happy to interact and answer any questions or receive any comments that you have. Thanks for your audience.
Thank you, David. I think sometimes as clinicians working in the field, as I know many people who are on the call are field workers, we don't often talk about these kinds of topics, but I think it's a really good challenge that you've put forward to us today. So does anyone have a specific question to David about the topic? It might be the first time you've heard of some of these suggestions or ideas about how to become an advocate or how to advocate in your workplace or your communities. Does anyone have a question specifically? David is our expert here in Kenya. As he shared, he's been 15 plus years advocating for palliative care, which is, what age did you start advocating for palliative care, David? Because you don't look old enough to be doing it for more than 15 years, but I'm just joking. Does anyone have a question for David? I know recently with World Hospice and Palliative Care Day, we have had quite a bit of interest from this region to advocate really for care of patients in humanitarian settings in East Africa. I know Annalise is one of our great advocates. She spent a lot of time putting together some content to share online during our World Hospice and Palliative Care Day sessions, and I know probably many of you are advocates in your area. Well, I think David isn't going anywhere, as far as I know. David is around. He's one of our faculty members for this program. So if people have questions, we can definitely pass them on to David. Looks like maybe one has come through the chat. Okay, Lydia is commenting that she really appreciates where we have to ask ourselves questions related to advocacy. Perfect. So we'll probably shift over now to our case presentation. So when we do our echo calls, we have a session where we talk about maybe a new topic that you haven't heard of before related to palliative care, or how you can incorporate that into your work. And then we shift in the second part of our calls to a case. So a very clear example of the topic that we have just talked about. So I'll now introduce Dr. Megan Doherty. She's one of our faculty members and is actively involved in ECHO programming and training of palliative care. And she's going to bring us an example from Bangladesh. So welcome, Dr. Megan.
Thank you very much, Erin. And just give me a sense of how much time you want me to speak for. Is it 20 minutes or is it less than that?
I think we're still okay to go for 20 minutes. Yeah, I think we'll aim to finish around in the next 30 to 40 minutes.
Okay, thank you very much. Perfect. So warm welcome to everyone and so glad to see you all today. There we go. So it's a little bit of a different case because like it's not so much about a specific patient. I wanted to tell you some of the things we learned about how to advocate for palliative care in humanitarian settings, in specifically when we did this in Bangladesh in the refugee camps there. And hopefully some of those lessons you can take, and maybe there's some ideas for how it can work in Kenya and East Africa. So I sort of came with two questions is how do we, I thought sort of the area of advocacy that seemed to be of a great need in the humanitarian settings was just awareness about palliative care. So how can we advocate for, like, just make people aware of the need for palliative care in these settings? And especially how do we help our supervisors and our managers who often are not palliative care trained people, or maybe haven't even heard of palliative care, how do we help them understand the need for palliative care? And I think that my examples and what I tell you today hopefully will answer these questions. So I want to tell you about this little patient, and he has given permission that we can share his story. So his name is Mojibur. He's 10 years old. And this is him with his mother and his younger sibling. And he came to Bangladesh from Myanmar in 2017 because there was a lot of violence in Myanmar and they were forced to flee. And during that time, his father went missing. They never were able to find him again. They kind of assumed that he was killed in the violence as everyone just kind of fled. So this is their home. This is where they're staying in Bangladesh in a refugee camp. You can see their house is very informal, just made of some plastic sheets and bamboo. And then as soon as he gets to Bangladesh, he gets diagnosed with an osteosarcoma, which is a tumor in the bone in his leg, in his right femur. So, you know, the example is that this can happen in any setting. We're going to have children and adults who, wherever they are, they're going to have these serious illnesses, like what David talked about. You know, the conflict happens around them, but they still have these illnesses. And in this setting, I don't have the video to show you today, but you can see here his face, he's crying, he's in a lot of pain because he was having trouble moving this right leg and it was really hard to walk. And so this is the situation when we met him in the very beginning. And I'll tell you more about him as we go along. So how we found him is that when the crisis in Bangladesh started, when the refugees started to come, we said, I think there are a lot of people here who have illnesses that are serious, that are chronic, that are non-communicable, like what you see listed here, that we need help. And we actually went around and interviewed many of them to find out what did they actually need and could they speak for themselves about what it was. So that idea of advocating together. This is how we went into the camps. These are some of the young helpers who we had. They were Rohingya members of the community themselves. We trained them, and then they would go and ask people, can you tell us about what's wrong, what's medically wrong, and how we can help you, and what do you need? And so they would talk to people who were seriously ill in their houses and just interview them. Here they are again. There was 10 of them. There was some women and some men, and they had training. They had support from myself and another physician, Dr. Farzana. They did 2-day training with role play before they went out, and we supervised them in the field. And we did this in partnership with another NGO that helped us out. And I tell you about these partnerships just to sort of illustrate the idea of you can't really do this alone. You know, we went in, we have the expertise in palliative care. We know which patients might need our help, but, you know, I wasn't equipped to, you know exactly about the camps. This other organization, Obat Helpers, had already rented this house you see here, so we could use it for training and as like a base from where we could go out and do the surveys. And they had already been connected with these workers so that we knew that these people had been screened and they were suitable to work with us. So those partnerships are really important. And what did we find when we talked to these individuals who were seriously ill? Interestingly, they actually had, in this setting, pretty good access to healthcare. They went to health facilities. Most of them had already been to a health facility after arriving in the camps in the first 3 months. But whenever they would go, the visits were quite unsuccessful in fixing or addressing the issue that the patient had. The patients reported many barriers with accessing healthcare, like lack of money, because they had absolutely no money. The treatment wouldn't be available, like the little boy Mojibor in the first slide, that he went to the hospital, but the hospital said, we don't have any treatment for this. We don't have anything we can do to help him be better or be cured. And then transportation in our setting was a big issue. The camps were built in a jungle. It was very hilly. There were no roads initially. And so it was very hard to move sick patients because they couldn't walk, and walking was really the only way to get around. The patients told us what they needed, and we asked them an interesting question, just what are the things you need the most? And people said medication, because 60% had stopped taking their medicine because of the cost of the medicine. Money, food, pain relief, and someone to help care for them were also big problems for many people. And then we also interviewed the caregivers, because the caregivers bear such a burden for providing most of the care, right? There's no structured caregiver, it's all family caregivers. So caregivers said it was very physically demanding, they didn't have much help. 38% said that it caused them sadness or anxiety, and there was a lack of money or time to do other things that they needed to do. In our survey, when we were first understanding what's the health situation for these individuals, we also did some other types of assessments. We went to a lot of health facilities that were serving the refugees to look at, do they have opioids like morphine, which is very helpful for when patients are having a lot of pain? What do they have to support children? And so this is a picture of the Red Cross field hospital set up where we went. This is the actual, they have like a small children's room or playroom within the field hospital. So this is a lady who's sort of like a supervisor. And then if children were sick and they were in this hospital, they could come to this tent and do drawings. You can see lots of drawings on the walls, some space on the floor to play and games and things like that. So these things are really good because, you know, if children are sick and they're in the hospital a lot, these are really important to help them cope with their illness. We also did a pharmacy survey where we surveyed all the pharmacists in the area about which essential palliative care medicines they had, to know if they had any pain relief, any medicines that would be really important for the palliative care patients. And then we again liaised and connected with other NGOs. In this case, this is Handicap International, to say, what are you doing for seriously ill patients? Because we knew they were doing some things and we didn't want to duplicate. So these are just examples of some advocacy. Then once you have ideas about what's happening with the patients, once you have results, you have to publish this, you have to get this out, right? You have to get people to know what you know. So we had a report. This is a picture of the report that came out, and you have to get it to the right people. So in humanitarian settings, the right people are often quite different from in the normal health system. So for us, it was the World Health Organization who we had to get them and give them a presentation and give them a report and tell them what was happening. And the IOM, which is the International Organization on Migration, which is a United Nations organization. So these in Bangladesh were the important players, and we had to share our data with them quickly. And then later we did a research article that was published. It took 2 more years because that's how research goes, it's very slow. But really we put the priority on this advocacy report, which was much more like speaking to non-specialists, non-palliative care specialists. So a few of the lessons that we learned, which I think are transferable to your setting perhaps, is when you're doing this kind of advocacy where you're assessing needs, having local interviewers is very important. So hire people, train people from the community where you're doing your survey, because they will speak the language exactly right, and they will understand all the cultural nuances. Making sure you adapt your interviews to what's relevant, and that's what our interviewers helped us do. And they are also just so comfortable and familiar with the local situation. And then just think about, how do you actually assess what people need? So really, it's important to have good tools that actually ask the right questions and assess and refine those tools. We did some pilot testing where first we went out and surveyed 20 people. Does the survey match, the information we want? Sorry, the slides are advancing automatically. And then talking to patients and caregivers, talking to health facilities, looking at opioid availability. These are all important. And then just thinking about, once you have those results, how do you disseminate them, share them, get people to do something with them? So that's what I'm going to tell you about now, is how we actually implemented this whole program. And I'm going to just go to this video and oops, sorry. I want to show you this video. It's a very short video on palliative care, but I think it's a really nice thing to show you. So give me 1 second.
Palliative care is something that works with the diagnoses which are incurable, for example, cancer, many of the bedridden patients with paralysis. So the way we look at them, we think about to improve the quality of their life, relieve their sufferings, as well as their families. In palliative care, there is a physical part where we do mainly the symptom management, and that symptom includes pain, breathlessness, insomnia, and nausea, vomiting.
One of our services is empowering the patient's relatives, patient caregivers, which definitely helps the patient, as this type of patients cannot always come to the facility, to the hospital. So if their caregivers can help them, they can help themselves and empower themselves, that help them more.
Then we do psychological care, as breaking off bad news, having a conversation with family regarding what we can do, what are the options available here, and what can be the next plan for this patient. And social part also, because in this country, even in this Rohingya context also, there are some stigma regarding some diagnosis. We do communication with spiritual leaders like Imam, Maji and Mullahs here to make them understand what palliative care is. We met patients' relatives who said, I know my mom is gonna die, but if you could do something to relieve her pain. There is still some way you can think about relieve the sufferings, not indicating whether he or she will die or their survival rate is so good, or disease prognosis is so good, but you can think about a dignified, respectful service to all of them, irrespective of their ethnicity, race, age, and sex.
Good. So I hope that worked okay for you to see, but that just shows you the idea of what we did implement. So a very basic program of palliative care that we were able to implement after we showed there's so much need. And if we go back to our little friend Mojibur, we had seen him before he was diagnosed, but then once we had this program, we could visit him and we could make sure he had pain medicine. And then he was much better. He was able to walk better. He didn't have so much pain. And his mother had a lot more emotional support. She had said in the beginning, they came home from the hospital with this diagnosis of incurable cancer. And she thought, should I just poison him because I don't want him to suffer? She was just totally distraught. But the visits from our palliative care team helped her know, okay, it's okay. We'll be with you. We'll support you, whatever happens. And this is another video I'm not going to show today, but just giving you more of the idea of what we were able to implement. And thinking about when you implement, these are all the people you have to influence. You have the patient and the family, but you have to think about how you're going to bring in all your different team members. And I don't have time to go over all that today, but just things to think about. And if you look at this program, One interesting thing we found is that it didn't just serve the refugees, it also served 1,000 patients per year from the local population, the host, we call them the host population, the Bangladeshi population. And we said, well, how did you know to come, and like what sort of made you aware of this program? And they just said, well, we've heard about a service which works for those with incurable diseases, and that is why we have come. And I tell you this because I think that, you know, if you do a good service, even if it starts very small and it's just seeing a very few patients and you don't think that you're really reaching everybody who needs it, then it will travel. People will start to know this is a good thing, and the patients will actually come and drive the support forward, which is one of our experiences. And then lastly, I'll just share some of the major challenges and a little bit how we address them. So an initial challenge was, and it still is to make healthcare providers and managers understand why palliative care is important. We still have the question from many people, including a lot of physicians, saying, why would you be willing to work for people who will die soon? So they don't see the point. They think, why would you do that? Those people, you know, they're going to die, just leave them aside. So getting that piece about the awareness, talking to the managers and the other healthcare providers and saying, these patients are suffering, they have a right to pain relief, they have a right to good care. And of course, the use of morphine is always a controversial issue. People haven't been trained, they don't know that this is a safe and effective and a very important drug for people who need palliative care. So a lot of advocacy about that. And, you know, it's been 5 years since we started this program. It's been 5 years since people have been talking about putting palliative care into humanitarian responses. It's been 5 years since the WHO released guidelines about how to put palliative care into humanitarian responses. So why is it still not being done? And here are some of the big things we found. Priority setting. So the question of how is it possible to ensure palliative care in the absence of basic curative care? And so this is a myth. This is a wrong belief that people have that we have to address, because we now know that it's not that you have to choose one or the other. You don't choose palliative or curative. You don't choose to do a program for palliative and not for curative. You make a good health program that addresses both. You say, we're going to focus on making sure people have good symptom relief and, you know, getting them the care that focuses on their disease as well. If they have diabetes, making sure they get the treatment, the medicines, insulin, what other medications for those conditions. And funding, this is another myth. You know, and this comes from the humanitarian background. Sometimes they feel like we're heroes who save lives. That's what's in the imagination of people who give money to humanitarian causes. Like, quickly, we got to save these people. But, you know, for NCDs and serious illness, you need funding that continues. It's not just about saving lives, it's about relieving suffering. Expertise and guidance is another big gap. And I'm so glad you're all here today and learning, because you will be experts and you will be guiding others. Teaching it, because people get so caught up in how do I handle a crush injury? So teaching palliative care for humanitarian health workers, which is what I do all the time now, and is so important, because you don't just need to know how to handle a crush injury. If there's an earthquake and someone's injured their limb, you need to know how to manage the pain of someone with advanced cancer, the symptoms of someone with dementia. And cultural concerns. So many times when you go into a humanitarian response, you're dealing with people who are not from your own community. So how death is managed and how death is a social religious construct is different from what some foreigners might be used to. So again, that goes back to using and working with local people who are part of the community, who guide and partner with you. And in this case, we had a lot of local partnerships. I've shared a few, and then there's many more, and I could tell you all about different ones. But of course, the IOM, the International Organization for Migration, was very important for us. They funded the palliative care project that I showed you in the video. PallCHASE, which is the international network supporting and connecting palliative care providers all around the world on humanitarian issues. And then we had local organizations. Fasidin Khan Research Foundation is a local Bangladeshi palliative care society. And then don't forget, and I think it's really well done in Kenya, don't forget your National Palliative Care Association like KEHPCA, and the local palliative care experts can really be a support to a humanitarian program. And so I hope that what I've said today has really told about how we create awareness in terms of assessing and documenting the need for palliative care builds awareness, and then spreading that by talking to the key players, and how this will help us with our supervisors and our managers and helping them understand palliative care better. So I'll stop there. And I'm very happy to answer any other questions.
Thanks so much, Dr. Megan. I think as we, again, like today might be the first time you've been hearing about how to become an advocate. I think it's really helpful for us to see and hear the examples of what's been done just in the really recent past in Bangladesh, and how palliative care providers in those settings have really been empowered to make a big difference in their programs and in the lives of their patients. Does anyone have any questions? There's been one question from Lydia. She shared on the chat. The question is, where do I start? I think this is a good question for David. David, where do we start? And how do we do this regarding advocacy? From what Dr. Megan has shared, obviously we can see the need is huge, right? When we think of palliative care and the fact that many of our colleagues in humanitarian settings may not even know what those words mean. So Lydia has shared that in her country, there are many children who need palliative care. And she sees it would be a good help for parents and caregivers, but where do you start?
Good question. And I think the start is guided by our needs. So what need is there? And then we start to ask ourselves, how do we want to address that need? Who do we want to be part of the change that we need to see? How do we mobilize them to be part of our discussion point? So in terms of responding to the needs of palliative care, depending on where we are at, it begins with a conversation, one with self, and secondly with the people that are around us, and thirdly with the systems that are existing. And eventually when you have a dream team, you're able to draft your strategy and then work towards achieving that strategy. I think I would respond it that way, in a very general way, unless there is now some specific question in terms of the steps, then I can come in.
Yeah, I can even pass it on to Dr. Megan. So Lydia, I think Lydia was saying she lives in Lesotho. I believe on the chat she had earlier introduced herself. So Dr. Megan, she was asking about how to advocate for children. Is this sort of advocacy different than our other palliative care patients? Is it even more different in humanitarian settings or settings where there's very limited access or conflict? Do you have any thoughts on where to start, especially when we advocate for children in these settings?
Yeah, I mean, I think I really echo what David said, and that's why I focus on needs assessment, is because I think you don't have to do a big needs assessment and talk to many, many people, but at least going out and talking to 5 to 10 patients and having a good understanding of really what are the challenges they're facing, because you will not understand it until you talk to them in detail. It's not just about having a sick child, it's about that they don't have food or childcare or transportation. And so you have to engage with them to listen and get their voice to be, you can amplify their voice, but first you need to really understand what's their message and can you share that? And then I did put just now in the WhatsApp group one slide, which I didn't show, but I think all these things go together. So having the needs assessment and then a little bit of storytelling, like having a patient and if you can get permission, tell their true story, like how I told Mojibor's story. And that story we had in our advocacy report, and we had a little video, and it's more real when they see one patient, even if the problem is 10,000 patients, just to see one and be like, oh, he's really suffering and this helped him and this is what he needs is important. And then it's persistence. It's just going and talking to people, and you don't always know who actually makes the decisions and who's the important person, right? because in humanitarian settings, like at first we didn't really understand how they worked, like who's in charge, basically. So we talked to a lot of people. Some of them we realized didn't make any decisions and they were not the right people. But we just would go around and meet anybody who would agree to meet with us and tell them what is palliative care and what we found about how all these patients need palliative care and what we want to do, which is help them with this home-based project like what I showed. So it was like about a 10 or 15-minute chat. And then if they had questions, we would like answer more things. But basically anyone who will meet with you, we would go meet with them. And then we really started with this small project, just like with a few patients, getting them morphine, showing that it was possible, because then we could, when we met with people, we could say, look, it's possible, we are already doing it. Even though if it's only for 40 patients, it wasn't for the 10,000 patients that really we wanted to do. That way you can prove that it's possible, because otherwise they just say maybe later and, oh, how do you know it's going to work and all this stuff. And we wanted to say, no, we already know it is working. We are doing it. So those are some ideas, but it takes time and energy. It was very draining in the beginning. It was very discouraging. We felt like we were not making any progress. We talked to many people, and for like 2 years, like we just felt like nobody heard us. And then all of the sudden, somehow it goes, and then people start to listen. So you have to have the long view.
Yeah, and I think another thing, Dr. Megan, I think when you did your work, you didn't, although you were a small team, it wasn't in complete isolation. And I think that's why groups like our group here in East Africa, and even the global network of PallCHASE, becoming a member of KEHPCA, which is our national association here in Kenya, it all really does make a difference, because you can easily side chat someone, or you can somehow rant or commiserate with one another, and somehow that does give you courage to keep going. I think it's just a testament. I know I just made a joke earlier about David's longevity with being an advocate for palliative care, but I think it just shows you that it is the long haul, 15 years. And David, I'm sure when he began advocating for palliative care in Kenya, couldn't have anticipated where palliative care would have been 15 years later. And I'm sure some days it feels like, oh, I wish we could have done more, or I wish it was further along. But when you do sit back and see all that has happened, yeah, I mean, advocacy does work. It's because of people like David and his team at KEHPCA that they've been able to accomplish all that they have. And the same for Dr. Megan and her team in Bangladesh. So yeah, just keep on keeping on. We are here. We're here to support you. Of course, because of COVID, the silver lining is that we are all very somehow connected virtually. So although we sometimes can't necessarily be in the setting where you are not doing your work in vain, and we are here to support you. We have a question from Marie, and we probably have time to take 1 or 2 more questions. So put them in the chat or raise your hand. So her question, I might pass this to David, and then maybe Dr. Megan can comment after. But she has said they have a great need for educating healthcare staff, especially nurses. Do you know of a nursing program for nurses that could be used in Lebanon? Because she's been asked to give a course, a 10-hour course for healthcare workers. It looks like for long-term patients, so maybe patients that are in a hospital for not just short amounts of time. Do you know of any courses, David, or access to material?
Lebanon. Okay, the course that comes immediately to my mind is the higher diploma in palliative care course that is offered by the Nairobi Hospice in conjunction with Oxford Brookes University. And it runs for 18 months, and it is like a distance learning course with some 2 or 3 weeks of face-to-face for some bit of practicum and instructions. The other courses would probably be the short courses that are provided depending on different kind of an arrangement. either virtually or physically. So probably we could discuss further and see there could be opportunities. I know Hospice Africa Uganda also offers those kind of courses, and sometimes they could be tailor-made for purposes of meeting certain needs. KEHPCA has an online training system that will be, actually we will be pilot testing it in the next 1 to 2 months. Hopefully, eventually we'll be able to roll it down for people to learn by themselves at their pace. So that's what I can think for right immediately here.
Yeah, Marie, I can also, I mean, David is a full-time employee of our National Association here in Kenya, so I can also connect you with him, and maybe we can chat about it offline. It seems like in Kenya we do have that higher diploma, so that would be like a after nurses have graduated. But of course that's quite expensive to do, and they would be back in school. But I think there's a huge variety. As Dr. Megan also said, she has some resources that we could adapt to the Lebanon context. So that can also be there too. So yeah, would you mind, maybe you can send me your, I don't know if I already have your details.
You know, I personally, I have my diploma. I'm a palliative care nurse from Lyon.
Yeah.
And I've been working here in Lebanon since 2010 in palliative. But I would like maybe as a help to have maybe a program, you know, to have a structure, how to give the courses, you know. This is what I feel I don't really have. I give courses from time to time, but I would like to have a structured structured program so it can be common to everyone, something adapted to what you are, the advocacy you are working on, to the training you are working on, you know.
Yeah, let me just share our email and maybe we can arrange something. And we do have some contacts in the Middle East as well. So I'm sure with some of our connections, we can definitely make something work in the next few months. Great. How many nurses are you working with?
They are, I didn't know, I think about 20 nurses. It's a long-term hospital, you know, it's more geriatrics, and they are starting to be interested in palliative care.
Okay, oh, neat.
And
yeah, let me just share. Let me share our email, and then we can definitely be in touch.
Great.
Any other questions regarding advocacy or the examples that we heard today from Bangladesh, or comments? Okay, so well, I do really appreciate and thank you everyone for your time. I think it's been a really interesting session, a little bit different than we do have done in the past, related to more very specific palliative care skills. But I think it's really important, especially as we continue on this journey of supporting one another in settings where we may not have such a strong voice yet. So hopefully you feel a little bit empowered today. Again, David isn't going anywhere as far as I know. So David, please, do you mind sharing your contact details on the chat? And David is one of our faculty members, so he'll be around in the future too. We are doing our mentoring sessions, so they happen every 2 weeks. So please invite your colleagues that are working with you. They're open sessions. You can join, you don't have to register for the whole course. And soon in January, we'll be offering the introduction to palliative care again. So please look out for that. So our next session will be in November, on November the 8th. And we do hope that you can join. I'll just put in the chat one more time the link to our WhatsApp group. That's the way we communicate mostly. And you're welcome to join us that way and pass on your email details. So thanks so much, everyone.
What time is it now? What time is it now at your where you are?
Yeah, so it's 5:20. What time zone are you in?
Here it's 5:22.
5:20. So we're at the same time. So next,
Okay.
not this coming Tuesday, but next Tuesday, November the 8th. We'll have another session at 4 to 5:30.
4 to 5:30. Okay.
Yeah. Yes,
Anyway,
you're welcome to join.
we will receive an email, I suppose, or I have to.
Yeah, if you join I just put in the WhatsApp, we've been communicating mostly by WhatsApp. So if you join the WhatsApp, then you can get the link that way.
Okay. Okay.
Great.
Thank you so much. Thank you very
Okay,
much.
bye everyone.
Thank you.
Thanks for
Bye-bye.
joining today.
Thank you. It was great. Thank you.